All right, so I will share my screen. All right, and so here's the study guide. Oops. All right, so the exam two is going to cover weeks 4 to 6. It's 50 questions, so combination of select all that apply, your multiple choice, and math. You have 75 minutes, again, 50 questions. So here we go. All right, so this is the exam two study guide. Did you fill out your study guide?
Yes, I started it.
All right, awesome. I'm going to make it a little bit bigger so I can see it. All right. So it talked about vulnerable populations. So vulnerable populations, generally speaking, they have poor health outcomes compared to other people in terms of morbidity and mortality. They have a higher prevalence of chronic illnesses, um, like your hypertension, higher levels of communicable diseases including tuberculosis, hepatitis B, what else? Your sexually transmitted infections, as well as upper respiratory tract infections, like flu. They also have higher mortality rates, than the general population because of poor living conditions, diet, health status, crime, violence, and that includes your domestic violence. So the first vulnerable populations are pregnant adolescents. So when we think of pregnant adolescents, what are some of the special considerations that we would take into consideration with our pregnant adolescents? Um, there's several challenges that, when we look at teen pregnancy, they have higher rates of sexually transmitted infections or sexually transmitted diseases, higher incidences of addiction to drugs and alcohol, poor nutrition, status, as well as higher incidences of poor health outcomes. Um, they're especially pregnant, worried about nutrition. They're, more less likely to want to gain necessary weight that's needed for pregnancy. Homelessness is another issue with our teen pregnancy or the pregnant adolescents. So we have to, assess for their um, home status, um, because they may be runaways, or their parents haven't accepted their pregnancy, and so they may be living on the streets. So one of the things that we would look at is making sure that we are scheduling the prenatal appointment. That's going to be a priority to ensure early, as well as continuous blood or prenatal care. We know that that's crucial for both maternal and fetal health. Um, Elevated blood pressure, seeking late prenatal care is a significant concern when we're working with this population. And then, of course, homelessness, right? How are they going to get to their prenatal appointments? How are they going to care for themselves throughout their pregnancy? Um, when we look at the important assessment of a new teen mom, observations, the primary goal of postpartum visit would be to assess knowledge regarding normal growth and development. Um, that helps to avoid unrealistic expectations and frustrations, which could lead to child abuse. So again, primary goal of that prenatal appointment is to assess the knowledge of their growth and development. Lack of familial support is also a significant factor that contributes to postpartum depression in our adolescents' moms. There's also a direct correlation between poverty and poor health outcomes. Poor teens are 3 times more likely to drop out of school as their non-poor counterparts. So we want to ensure that mom continues her education and finishes her education. So like, some schools have programs, like homeschooling, that will assist parents or assist pregnant adolescents or teen moms to finish their education. And that, increases their chances for a better future, which also improves healthcare over the long term, across their lifespan. So it's really important to keep our pregnant teens in school during the pregnancy and then have them return as soon as possible after the birth. With any questions on pregnant adolescents.
No, but I feel like we went over this already, didn't we? Is this going to be on our test too?
This is exam two, right?
Yeah.
Yeah.
Oh, I don't know why I feel like we just, it seems, I don't know, we did this already.
With our LGBTQ plus communication community, we have the ethical obligation to provide culturally competent care to our LGBTQ families. And so some nurses may have some discomfort, discussing sexual orientation with their clients, but it is necessary part of the assessment process. And it's also important to provide clients with a safe environment so that they can discuss their sexual orientation. Um, Homosexual behavior is not uncommon in adolescents. And, it's just a way for them to explore alternative lifestyles. So again, providing culturally competent care, having an understanding of our own personal beliefs and feelings about working with this population is really important so that we can make sure that we are kind of checking that at the door, so that we can provide that care. So open, non-judgmental, sexual and social history is the key to building trust with these clients. Don't ever make assumptions about the clients based on their appearance or their sexual behavior. Um, Ask those open-ended questions, right? So we can get as much information as possible, about their lifestyle. So instead of like, are you married? Ask if they have a partner. What do you call your partner? Rather than just assuming. Um, the Centers for Disease Control and Prevention also provide recommendation on the screening and prevention of sexually transmitted infections. So yearly screening for HIV, syphilis, gonorrhea, herpes, chlamydia. Um, it's 3 to 6 months if they are extremely high risk. So if they have multiple or anonymous sex partners, or those, of course, that are using any illicit drugs in addition with sex, right? We want to increase the frequency of that sexually trained or the STE screening. Mental illness, in anxiety, mood, eating disorders kind of all fall into this. So generalized anxiety disorder is one, which is a person who experiences persistent, unrealistic, or excessive worry about two or more life circumstances for 6 months or longer. Those are they're the ones that are going to exhibit the symptoms of generalized anxiety disorder. Buspar is most often indicated for the treatment of anxiety. So one of the nice things about Buspar is it's one of the anti-anxiety medications that we can use long term. Unlike your other ones like your Xanax and your Ativans, that are generally recommended for short-term use. Buspar is one that can be used for long-term anxiety. It's not recommended for like your paranoid thought disorders, schizophrenia, drug or alcohol withdrawal, but it is a pretty effective medication. Your phobias, a person with a phobia experiences excessive irrational fear of a specific activity. situation or an object. So that can lead to avoidance or extreme anxiety that interferes with normal responsibilities, routines, even sometimes performing their ADLs. Your OCD, they experience obsession, recurrent or intrusive thoughts that they cannot stop thinking about, and those thoughts will create anxiety. Um, and a compulsive act is just something that they feel compelled to perform frequently. So, I mean, it could be checking the door locks, it could be washing their hands, brushing their teeth. I mean, there's so many different things that could fall under that. But they're compelled, they have to complete that compulsive act. PTSD, which is your post-traumatic stress disorder, is characterized by a previous event that involved threatened or serious injury to self or others, during which they experience intense fear, helplessness, or horror. And just remembering those events produces feelings of intense distress, along with anxiety, nightmares, and or flashbacks. And flashbacks are a dissociative experience where the event is relived, and usually those events are recurrent. Bipolar disorder is they experience episodes of extreme sadness, hopelessness, helplessness. And then in between, they have periods of extreme elation and hyperactivity. So they'll have episodes of major depression and then manic or hypomanic behavior. The most common medications for your bipolar disorder is your lithium and mood stabilizers. With lithium, if you remember from pharmacology, um, you want to make sure that we encourage normal salt intake. So they need to drink about 25 to 3,000 mLs of fluids per day. We want them to avoid becoming dehydrated. So don't want those sodium levels to fluctuate. They should take it with meals to decrease gastric distress. They also want to avoid things like caffeine, um, that because caffeine has diuretic effects. Again, we don't want them to become dehydrated. And if they have any diarrhea, vomiting, tremors, lack of coordination, then we want them to report that to their healthcare provider. They also need to have their lithium levels drawn periodically to make sure that they're staying within those normal therapeutic ranges. Eating disorders. The goal of treatment for eating disorders is to restore nutritional health and a normal body weight. Long term would be to achieve a sense of self-worth and self-acceptance that is not based on their appearance. So a lot of it with your eating disorders is those nutritional assessments, and what can we do to encourage them. A lot of patients with eating disorders, depending on the severity, will require hospitalization. And of course, they'll have to have long-term psychological counseling or cognitive behavior therapy to follow them, as well as dietitian to help them get back on track with their nutrition, because the negative effects that the um, eating disorders can have on their bodies, as far as, electrolytes and mineral and sorry, electrolyte mineral imbalances, things like that. Let's see. When we look at alcohol withdrawal, so alcoholism, um, one of the early signs of withdrawal can be irritability. So one of the priorities. of care. Sorry, let me let Sarah in. One of the priorities for care is to prevent the client from harming himself or others. So we want to provide a low stimulation environment to maintain the client as calm as possible. But again, that primary or that priority care is to prevent them from harming themselves or others. So monitoring their vital signs closely, reporting any, abnormal findings, making sure that we're providing or reorientation to reality, address any hallucinations therapeutically, um, making sure that we're providing for adequate nutrition and fluid intake to maintain those statuses. What else? And then once they're stable, we want to discuss the possibility of treatment. So therapy would be then to, confront the patient's denial, encourage self-diagnosis of alcoholism. There's group therapies, there's individual therapies, there's, of course, cognitive behavioral therapy that all can assess. Group therapy helps to break through the denial, gives them a new sense of belonging and identity, so things like Alcoholics Anonymous and other groups. And then your behavioral therapy will help with self-discipline. It also will help to discourage impulsive behaviors. So it kind of gives them sense of assessment or helping them to recover. Sorry. Um, we know that alcoholism also is associated with, by B vitamin deficiencies, like your folate, low magnesium, low potassium, iron deficiency, anemia. They're prone to malnutrition because of skipping meals. Alcohol absorbs better on an empty stomach, so they get it into their system faster without having food in there. It is a central nervous system depressant. So drowsiness, respiratory depression, lethargy, confusion, um, are some of the effects of alcohol on the body. Your blood alcohol concentration is determined by the concentration of alcohol in the drink, the rate of drinking and the rate of absorption. Again, that's going to be slower in the presence of food. How fast they metabolize the alcohol, and the person's weight and the person's sex all affect how the body is affected by the alcohol consumed. The amount of alcohol the liver can metabolize per hour, it's about a quarter of an ounce of whiskey, about 4 ounces of wine, or 12 ounces of beer. So that's pretty significant amount. But then if you're drinking more, the body can't metabolize it that fast, which leads to, the intoxication. Tobacco, cigarette smoking is associated with cancer, lung disease, heart disease. Knowing the dangers of, smoking and nicotine, that, things like education as far as avoiding alcohol, um, or I'm sorry, avoiding tobacco products, um, and even the vaping and the e-cigarettes. There's just as many chemicals and um, the oil is poisonous to kids. And of course, we know that there can be significant lung damage that occurs from not only the use of nicotine and tobacco products, but even from the e-cigarettes and the vaping as well. Secondhand vapor exposure, secondhand smoke exposure are both associated with health problems. So a lot of this is catching our adolescents, and prevention about smoking. Um, was going to say something and I can't remember what I was going to say. So your primary, right, would be prevention, providing education, as to avoiding your tobacco, your e-cigarettes, your cigarettes, your cigars, pipes, whatever is out there. Um, Again, kids are at risk of poisoning, if they ingest the oils that they use in the vapes. And of course, that secondhand exposure is also associated with health problems. There's also the risk for addiction and lung damage. I'm trying to think what else. And then, if they're exposed, they also increases their risk for using tobacco or the e-cigarettes as they get older, just from the exposure from being young. And of course, growing up with smokers in the household or around smokers, whether it's cigarettes, whether it's the e-cigarettes, again, that increases their risk for, using those devices as they get older. With cocaine and amphetamines, methamphetamines, they are stimulants. They are associated with cardiovascular complications, um, your increased heart rate, your increased blood pressure. The stimulant abusers exhibit high temperatures, high heart rates, high blood pressures, that require emergency attention. Other signs and symptoms of people that are using amphetamines would be frantic, excited speech. Um, what else? And then we had our week 5 concepts, which was death and dying and hospice and palliative care. So the goal of palliative care, according to the World Health Organization, is to improve the quality of life of patients and their families while dealing with a life-threatening illness, by reducing or relieving the symptoms of the disease. So we have our hospice nurses. The primary goal of hospice, again, is to improve quality of life, alleviate suffering, and improve end of life experience for clients as well as their loved ones. So the hospice, it's providing that death with dignity. Um, some of the particular um, functions of that hospice nurse, especially is to, facilitate effective communication between the client and the family, making decisions for the client and family will remove the autonomy and decision making, right? So we want to encourage autonomy, let them make the necessary decisions regarding their end of life care. And there's a variety of resources that are out there for your hospice patients. So we want them to have as much control as possible over what is going on with them, which is, a difficult situation already. Um, so we want to encourage discussion. We want to allow them to express their feelings, their concerns, and that will help to improve that communication and provide that collaborative relationship. We also have to take into consideration their spiritual practices. For a lot of people, their spiritual practices give them meaning for life. It'll influence how they react to crisis. And so incorporating some of their spiritual practices into their care, right, is going to provide comfort for them. We also need to focus, on keeping them comfortable, maintaining their dignity and their self-esteem. We don't want to keep them sedated. We want them to be as alert and as interactive as possible, so that they can still, have relationships with families, perform, still do stuff with their family while still being comfortable enough because we want to keep them as pain-free as possible. But again, it's about communication and what we expect and allow them to make those decisions. Um, Trying to think what else. So some of the interventions for your hospice patients, again, it's focusing on symptom and comfort care. One of the priority goals is going to be pain control. But again, we have to find, a fine line between pain control and keeping them sedated. Again, we still want them to interact and, with their families. What else? Um, Guidance, I talked about that. The stages of grief, which were at the beginning. Um, the first stage of grief is denial. This isn't happening. There must be a mistake. Um, the biggest thing there is to remain with the family member, just allowing them to, express their feelings, of course, accept the feelings that are occurring. And then just, assisting them through the process. Um, and then the bargaining stage, which, that is, like I promise I'll go to church every Sunday for the rest of my life, or I'll quit smoking, I'll quit drinking, whatever the bargaining is. We can just provide information, for, decision making at that process during that process. Um, and then once they get into the depression stage, they may need to have some mental health counseling um, to kind of help them through that stage of it until they get into the acceptance stage. Um, we look at the observations that we would see in a client towards the end of life. Um, Cheyne-Stokes breathing or Cheyne-Stokes respirations. Those are shallow breathing followed by periods of apnea. And then they'll just stop breathing for a few, and then they'll take another deep breath. Their skin, they may have some edema. Their skin also may start to mottle. So you'll see mottling, especially on the lower extremities. Swallowing reflex declines. Some of your clients that are getting ready to pass may start to drool just because they're not able to swallow the saliva. We can give them medications to help dry up some of those secretions. Incontinence also does occur towards the end of life as everything starts to relax. If there is a question of cause of death, so things like suspected suicides, deaths from injuries, that's when they'll do an autopsy. But generally speaking, patients that are in hospice, if they're under the care of a healthcare provider, then we know that they're terminal. Generally speaking, we won't do any autopsies again unless it is a suspected or something out of the ordinary occurs. With spirituality and culture. So culturally competent care, we've talked about this, requires that we have an understanding of our own culture, as well as any biases or stereotypes that we hold, that we approach everybody as unique, that we don't make any assumptions, that we don't place our culture above anybody else's, and that we consider traditional health practices in the plan of care. So an example would be your Jehovah Witnesses. We can't give blood and blood products, but they can have surgeries and other procedures. Um, Medication is acceptable even if the medication, except if the medication is derived from blood or blood products. Another one would be like our Jewish population, um, clients who follow a kosher diet, avoid meat from carnivore pork products, and fish without scales or fins. Um, Fruits and vegetables are considered kosher as long as there's no bugs present. Tuna, chicken, potatoes, apples are also considered kosher. Another example would be your Native Americans don't usually sustain eye contact in the same way as like your Europeans do, because they consider it rude. So really kind of having an understanding of some of the, cultures that you're going to be working with. Again, we treat everybody as an individual. Um, we don't treat every client the same. And we don't let, we you have to learn about their beliefs. And if you need to understand what their beliefs are, the best way to do that is to ask them. One of, other things about your cultures, time, cultures are considered, cultures are future, past, or I'm sorry, yeah, future, past, or present oriented, past oriented cultures. They value their ancestors and the past. They can sometimes have a preoccupation with past events, which makes it difficult for them to achieve future goals. Your present oriented cultures value the here and now. They prioritize quality of life, making decisions that make them happy in the present. And that can lead to decision making that fails to plan for the future, or even future consequences. Your future oriented cultures are more likely to make sacrifices in the present, in order to achieve future or long term goals. Um, and we look at language barriers with different cultures. Always remember the use of interpreters versus family members or children, to make sure that we are getting unbiased, information, that we're getting is all the information directly from the client. And then cultural competence is attained when the nurse makes the conscious attempt to learn about people of diverse cultures and look at the world through their perspective. And then we talked about legal and ethical issues. So the first step in ethical decision making, right, is identifying the ethical issue that is faced. The purpose of the ethics committee includes processing the ethical dilemmas, providing education, um, and providing policy recommendation and case consultations. Your ethical principles, non-maleficence, beneficence, distributive justice, and autonomy. So beneficence means to do good, the most good possible within the circumstances. So an example of beneficence would be to ensure adequate pain control. Um, Justice is providing, is treating everyone the same. I'm trying to think. So an example of distributive justice would be um, advocating for insurance coverage for hospice services would be an example. Non-maleficence means to do no harm. So, making sure that you're following your, rights on medication administration, your 3 checks, right? Making sure that we are avoiding mistakes with medications, with procedures, right? That we're doing whatever we can to avoid harm. Um, And then autonomy is to respect their right to make decisions. We give them all the information that they need to make a conscious decision about their plan of care. If they choose to not have treatment, that is their decision. We just provide the education. When we do, it's not our goal to change their minds. It is still, if they decide, just like, with your Jehovah Witness patients, if they decide that they don't want blood products, it's not our job to convince them to accept blood products. It's just our job to provide the education, and then respect their decision. Guidelines for appropriate documentation. So factual documentation contains descriptive, objective information about what the nurse sees, hears, feels, or smells. The use of inferences or assumptions without supporting document or factual data is not acceptable because it can be misunderstood. Avoid using vague terms like seems or appears, because those can be more of an opinion. So just like an example, when I first started nursing, um, we would document, client lying in bed appears to be sleeping or seems to be sleeping, right? Well, that person could just be lying in bed with their eyes closed, doesn't mean that they're sleeping. So we want to be really careful with the terms that we are using. Other things with ethical and legal, floating from one unit to another is an acceptable practice. We know, especially in hospitals, it's a way to help solve staffing issues. If I'm overstaffed on one unit, I can pull a nurse to another unit. Legally, the nurse cannot refuse to float, unless they have a union contract that says that they can't float. Um, or the nurse can prove that they have a lack of knowledge for the performance of assigned task. And so it'd be like, maybe a med surg nurse that's getting floated to the ICU or labor and delivery, and they've never had any experience in either of those. Um, and so the nurse needs to identify potential areas of harm to the client. But at the same time, they can identify tasks that they can perform safely. So like that would be me. Like if you try to pull me to L&D, I wouldn't know what to do. I would just like I could take vital signs and bring them back to you. But it's having just being honest with the information. Um, and, again, like I said, you can't say you're not going to float unless you have a union contract. But, if it's like med surge to med surge, usually that's not a significant issue. Then our week 6 concepts, we had occupational health, and environmental health. Talked a lot about the air pollution and water pollution. Children are much more vulnerable to environmental hazards. The exposures are more likely to lead to adverse health outcomes, especially during fetal development. And then after birth, again, the environmental hazards can still provide significant or produce significant effects in child. Um, Safety assessment in the workplace. So your occupational health nurse, right? We talked about some of the roles with them. They may conduct assessments of the workplace. They can learn about their work processes, the materials that they use, the requirements of the different jobs, the presence of actual or potential hazards, work practices of the employees, observe the effectiveness of safety education and equipment as well, right? Work processes, making sure like you're using, the safety syringes appropriately, that you're putting them in, the sharps container afterwards. It could be, observing hand washing, other equipment use. The occupational health nurse doesn't just work with nurses, it works with all departments. So, they kind of need to see how, each department does their work practices. They'll also see the various injuries and diseases that people can acquire from work or employment. No work is risk-free. Every industry has risk for hazards that are related to work. So depending, again, your occupational health nurses don't just work in hospitals, they work in other industries, well, pretty, oh, there's, I mean, your shipyards, your factories, um, anywhere there is a potential where we have heavy equipment or chemicals, they have an occupational health nurse. It just really kind of depends. Then we talked about client teaching. So one of the most important learner related barriers is low literacy. And so we may work with uh, individuals and populations who are illiterate or have low literacy levels. So yes, there are still people here that cannot read and write. And so they, kind of, or what's the word I'm looking for? They may agree to things that they really don't understand or say yes to things that they really don't understand, even if they, if we ask them, they may be embarrassed to admit their reading deficit. Um, and again, like they said, they may appear to understand when they really don't understand. One of the ways that we can assess clients' ability to read and comprehend is to give them something to read and read it to us um, and, acknowledge that they understand the material, which, even then can be a little bit more difficult because they may not want to read it in front of you. But that is one of the best ways that we can assist with that. Um, your cognitive um, domain of learning, that's your understanding, right? Your ability to remember and recall information. Your affective domain is how it affects you. And your psychomotor is, actually performing a skill. And so, this is like when we're teaching somebody how to check their glucose levels or give themselves injections, right? That's performing a skill. I guess in setting class, the see one, do one, teach one approach. They'll watch you do one, then they'll do it, and then they'll teach somebody else, like a family caregiver, family member or caregiver, right, how to perform that skill, and it just reinforces it. Discharge planning begins as soon as they are admitted, right? The goal is to get them well enough to be discharged. So as soon as we admit them, we are starting our discharge planning. And then teaching plan for asthma. So I can't remember, we talked about asthma earlier in the term. So some of the teaching plans for asthma would be to reduce their exposure to whatever their allergen is, if they know what their allergen is, reducing exposure to smoke, reducing humidity inside. We could also use things like HEPA filters, and there's allergy covers for pillowcases or for pillows, sorry, for mattresses. Um, but one of the big things is to, avoid the exposure. Again, if they know what their allergen is or what their trigger is, to try to avoid it. Um, and then have their asthma action plan in place should they have an exposure and need to initiate treatment. All right, so I'm going to stop sharing. What questions do you have for me?
I didn't have any questions. I feel like you thoroughly went over every topic.
Yeah, I don't, excuse me, I don't have any questions right now regarding um the stuff you went over. I'm gonna have to rewatch it since I was late.
It's okay. I did figured you might have had some connection issues or something because you came in and then you left and then came back. So I was like, figured it was just a connection issue. But yeah, I will post this shortly, as soon as it processes.
Thank you.
You're welcome. You guys have a great evening.
You too. You too. Thank you.
You're welcome.